Hi, and welcome to Nephrology. My name's Emma Holliday. I'm currently a PGY1 in internal medicine, but I'll soon be starting my residency in radiation oncology at the University of Texas MD Anderson Cancer Center. Let's get started. Every intern needs to know which test to order when in the workup of common disorders. So we'll begin by reviewing some of the common diagnostic tests in nephrology and what to do with the results. A common question on the USMLE Step 2 is, what is the best initial test? In a patient with pain upon urination, back pain, blood in the urine, frothy urine, or any other symptom that has anything to do with urine or the urinary system, the best answer is urinalysis. Urinalysis gives you information about protein, white and red cells, specific gravity, pH, and the presence of nitrites in the urine. Remember for the exam, the key urinalysis findings of a urinary tract infection. 1. The presence of pyuria, which is either seen as many white blood cells on microscopic analysis or a positive leukocyte esterase on the dipstick, plus the presence of positive nitrites on a dipstick. However, remember a thing about nitrites. Nitrites are only positive in the setting of a gram-negative urinary tract infection. Now, most of the bugs that commonly cause a UTI are gram-negative, but there are 3 notable exceptions. The Enterococcus species, Staph saprophyticus, and Group B strep are all gram-positive bugs that sometimes cause a UTI. So in those cases, you'll see pyuria without a positive nitrite. So what is the difference between the dipstick and a microscopic urinalysis? Because both can give you quantitative values and help you make a diagnosis on step 2. The dipstick uses a series of chemical reactions to tell you about the presence or absence of substances in the urine, and is typically reported on a scale from 0 to 4 plus to tell you about how much of that substance is present. In contrast, a microscopic urinalysis is when a person or a special machine evaluates and reports the number of cells per high-power field examined. As with most lab values on the USMLE Step 2, don't worry about the precise scale or normal values for each of these separate tests, because you'll be able to look up the normal reference values to assess severity. One thing I do want you to remember is that test makers have been known to present clinical scenarios where the dipstick and urinalysis give conflicting results. One classic case here involves a patient who has 4 plus RBCs on the dipstick, but no RBCs seen in the microscopic analysis of the same urine specimen. We'll talk more about this a little later, but what's the diagnosis? Myoglobinuria from rhabdomyolysis, or hemoglobinuria from a hemolytic process. Again, we'll talk more about this later. One substance we're particularly interested in when we order a urinalysis is the presence of protein. Now, the normal kidney does secrete some protein normally. It's known as TAM horseball protein. The tubules secrete it, and so the finding of trace proteinuria on a dipstick could be a normal finding. However, you should remember that normal kidneys never secrete more than 30 to 50 milligrams per 24 hours. In the case of tubular damage, more protein than normal can be lost in the urine. However, if you see massive proteinuria, which is typically somewhere in the range of 3 to 4 plus on dipstick, that's only found when the glomeruli themselves are damaged. So if you're interpreting the results of a dipstick for the presence of protein, it's a pretty easy correlation. If you see 1 plus proteinuria on a dipstick, that's equivalent roughly to the loss of 1 gram of protein per day. 2 plus proteinuria is 2 grams of proteins lost per day, so forth and so on. The finding of protein in the urine doesn't always equal something pathologic. Somewhere between 2 and 10% of the population has a transient proteinuria. Some benign reasons for having protein in the urine are positional and physical exertion related. The first time someone stands up after lying down for a long time, for example after they've been sleeping, they can spill a little bit more protein than normal into the urine. Likewise, after a long military march or something very physically demanding like a marathon, you can also see extra protein secreted into the urine. So let's think about test day. If we're presented with a patient who has symptoms of proteinuria, what is the best initial test? The answer here is either urinalysis or a dipstick, the same test we've been talking about for the past couple slides. So what do we do if that's positive? The follow-up test to that is going to be either a urine protein to creatinine ratio or a 24-hour urine collection. Both of these tests are going to quantify the amount of protein in the urine over a 24-hour period. This is helpful because it helps to average out all the positional and physical activity related variation throughout the day, and it gives us a more complete picture of what's going on with the patient. The thing to remember about these two tests is that they have equal accuracy. A single protein to creatinine ratio has the same accuracy as a whole 24-hour urine collection and analysis for protein. It's also got the benefit that it's a lot easier to perform than keeping a jug of urine on ice for 24 hours. For that reason, it's more often chosen by practitioners. And at the end of the day, a single protein to creatinine ratio is actually more accurate than a 24-hour urine collection because it doesn't depend on every single drop of urine being collected by the patient into the jug. Also, the numeric value of protein to creatinine ratio correlates with the grams of protein that would be found if a 24-hour urine sample had been collected. For example, a ratio of 2.5 protein to creatinine correlates to 2.5 grams of protein lost in 24 hours. Back to test A. What's the most accurate test for determining the etiology of why protein is being lost in the urine? The correct answer here is renal biopsy. Taking a look at the tissue under the microscope is the best way to figure out why the protein is being lost in the first place. There are some notable limitations of the dipstick for assessing proteinuria. The first is that it only detects one protein, and that's albumin. So what does it miss? The most notable protein that a dipstick won't pick up is Bence-Jones protein. That's present in the urine of patients with multiple myeloma. So what test would you order if you were looking for Bence-Jones proteins? The correct answer here is UPEP. That stands for urine protein electrophoresis. The final limitation of the dipstick is that it can't detect very low amounts of protein like 50 to 250 milligrams per 24 hours. And actually, there's a special word for protein in the urine that's too small to be detected on dipstick. We call it microalbuminuria, and we have to order a special test in order to detect it. Microalbuminuria is when the amount of protein lost in the urine is too small to be of any clinical significance. So you won't see the findings of frothy urine, edema, or hyperlipidemia. We typically order the test for microalbuminuria in our diabetic patients, and we perform the screening test yearly. Why do we want to know if there's microalbuminuria in our diabetic patient? Because it's got some important long-term consequences. Namely, it leads to worsening renal function, and for that reason it should be treated. Remember that the #1 diagnosis leading to dialysis in the United States is diabetic nephropathy. The key to preventing the need for dialysis is to detect it early, and to intervene early to delay the progression. Obviously, glycemic control helps this too. Now let's apply what we've learned so far to a clinical vignette similar to one you might see on the USMLE Step 2. Here we've got a diabetic patient who's being evaluated. The urinalysis shows no protein, but it does show microalbuminuria at a level between 50 and 300 milligrams per 24 hours. The question is, what is the next best step in management? Our answer choices are enalapril, kidney biopsy, hydralazine, renal consultation, low protein diet, or to repeat the urinalysis annually and treat when trace protein is detected. The correct answer is enalapril. ACE inhibitors or angiotensin receptor blockers, like losartan or valsartan, are the best initial therapy for any degree of proteinuria in a diabetic patient. What they do is they decrease the progression of proteinuria and therefore can delay the development of renal insufficiency in our diabetic patients. So now that we know the right answer, let's talk for a moment about why these wrong answers are wrong. Kidney biopsy is wrong because we already know the etiology of this patient's proteinuria. Remember that a kidney biopsy is the best test when you have no idea what's causing proteinuria in a patient. In this case, we know the microalbuminuria is most likely caused by the diabetes, so the kidney biopsy is not going to give us a lot of new information and is probably not worth the risk of putting the patient through a pretty invasive procedure. Hydralazine is wrong because even though it's a pretty good medicine for hypertension, it's not as good as enalapril for reducing protein loss in the urine. Additionally, it has more adverse effects than enalapril. Do you remember the side effect that's most commonly associated with hydralazine? It's drug-induced lupus. And the test for drug-induced lupus, remember, is a antihistone antibody. So what about renal consultation? You never consult on step 2. It's really difficult for me to think of an instance where consult a specialist would be the right answer on the USMLE, so don't pick it. Low-protein diet, actually decreasing the protein in the diet isn't going to decrease the amount of protein lost in the urine. Plus, if you are telling your patient to cut back on protein, they're probably going to replace that protein with carbohydrates. And remember, in addition to ACE inhibitors, the key to preventing progression to diabetic kidney disease is glycemic control. And a high-carb diet, low-protein diet, is going to be bad for glycemic control. So lastly, F, repeat UA annually. Remember, the key to preventing progression of diabetic nephropathy is to catch it early and to treat it early. So we wouldn't want to wait until the proteinuria is so bad that it's going to show up on your analysis. We want to go ahead and start treating it as soon as we detect the microalbuminuria. In addition to protein, another important substance we often look for in the urine on urinalysis is white blood cells. White blood cells in the urine is known as pyuria, and it can be present in a variety of different conditions. It can be present in inflammatory states, infection, or in allergic interstitial nephritis. Remember that neutrophils can't be distinguished from eosinophils just on urinalysis alone, and they can mean totally different things. Neutrophils in the urine typically indicate infection, such as a UTI or a urethritis, whereas eosinophils in the urine indicate allergic or acute interstitial nephritis. It's important to remember that NSAID-induced renal disease will not have eosinophils in the urine. So how do we detect eosinophils in the urine? The Wright or Hansel stains are the best test for this purpose. The finding of red blood cells in the urine is known as hematuria, and it can be caused by a variety of different things. Stones in either the kidneys, ureter, or bladder can all cause hematuria, as can a coagulopathy. Loss of or inhibition of clotting factors will lead to bleeding increased in all organ systems, including the urinary system. Infections cause inflammation, so cystitis or pyelonephritis can both be associated with hematuria. And cancer is a concern, particularly in older patients who are former heavy smokers. The urologist will often say painless hematuria in an older person who is a former smoker is bladder or renal cancer until proven otherwise. In addition to cancer, cancer treatments, namely cyclophosphamide, are associated with a side effect known as hemorrhagic cystitis, which leads to hematuria. Trauma, in the setting of a hard blow to the back that can damage the kidney, or a traumatic Foley insertion that can damage the urethra, can both lead to hematuria. And glomerular nephritis. We'll talk about this at length in a future lecture, but one of the hallmarks of glomerular nephritis is hematuria. The last thing I want to talk about here is hematuria that is actually a false positive. So to call something true hematuria, you have to visualize the red blood cells themselves in the urine. We call hematuria a false positive when there are no red blood cells present, but the urine looks red and it is positive for blood on the urine dipstick. This is the case in either hemoglobinuria or myoglobinuria. Hemoglobinuria can happen with any type of hemolytic anemia. Myoglobinuria can happen with any type of rhabdomyolysis. Typically, they'll describe either a crush injury, a really bad electrical burn, or a major trauma. One tip for test day. You'll want to know the buzzword dysmorphic RBCs. If they either say the RBCs were dysmorphic or they show you a picture of a red blood cell that appears to have twisted or kind of looks like a Mickey Mouse with the two ears, you'll want to think about glomerular nephritis as the cause for that hematuria. The red blood cells become dysmorphic as they get distorted moving through an abnormal or diseased glomerulus, which is what causes this finding. So it can be reassuring if you have your old smoker who used to smoke 5 packs a day, he has hematuria, you're worried about cancer. If they describe dysmorphic red blood cells, you can be reassured that it's probably not cancer, it's probably a glomerular nephritis. Okay, let's take a look at another clinical vignette. Here we have a woman who's admitted with trauma and dark urine. The dipstick is markedly positive for blood. The question is, what is the best initial test? Our answer choices are microscopic examination of the urine, cystoscopy, renal ultrasound, renal bladder CT scan, abdominal x-ray, or intravenous pyelogram. So what's the right answer? It is A, microscopic examination of the urine. In this clinical scenario, we just have a classic history for rhabdomyolysis. We have a woman who's admitted with trauma, her urine is dark, and the dipstick is positive for blood. So the next logical step is to actually take a look at the urine under a microscope and see if red blood cells are present or not. Remember that we can't actually call something hematuria unless we see the red blood cells in the urine. So now that we know what the right answer is, let's take a look at why some of these wrong answers are wrong. Cystoscopy is wrong because it's overkill for this clinical scenario. Typically, cystoscopy is performed once a renal ultrasound and a CT scan have both failed to show the reason for hematuria. It's invasive, it requires OR time, and it's certainly not ideal for an initial exam. Renal ultrasound is wrong because it also doesn't really fit the needs of this clinical scenario. What renal ultrasound is good for is determining kidney pathology caused by stones, cancer, or cysts. However, here in the setting of trauma, we should be thinking about an injury severe enough to cause rhabdo, and when choosing the best initial test, it's often the least invasive test that still might give you the answer that you're looking for. Along the same lines, a renal or bladder CT scan is also overkill for what we're doing in this clinical scenario. What a CT scan is good for is diagnosing stones. It would be the right answer if the urinalysis and the renal ultrasound failed to give you the information that you need. Abdominal x-ray used to be the test of choice for kidney stones, but since not all stones are radio-opaque, the CT scan has surpassed the abdominal x-ray as the best test in picking up stones. Lastly, intravenous pyelogram. This test is pretty much never the correct answer on the USMLE Step 2. The reasons that it's not the ideal test for anything anymore is that it's slow and it uses a contrast that's actually toxic to kidneys. We used to order it and use it a lot to diagnose stones or obstruction in the urinary system, but now that we have ultrasounds and CT scans, the intravenous pyelogram is really outdated and not really used much for anything at all. We talked a little bit about cystoscopy on the previous slide. So let's discuss it specifically. When is cystoscopy the answer on the USMLE Step 2? So you'll consider a cystoscopy when you have a patient with hematuria, there's no infection, and there's no history of prior trauma. In that particular patient, there are pretty much 2 reasons to perform a cystoscopy. The first is if other less invasive tests have not given you the diagnosis, and the order of the workup here is urinalysis, microscopic examination, renal ultrasound, and then CT scan. If all of those have failed to show you what's going on, go ahead and order a cystoscopy. The second reason to perform a cystoscopy is if you've seen evidence of a mass with some other imaging modality and you want to perform a biopsy to actually take a look at the tissue and make the pathologic diagnosis. As with most tests that allow for direct visualization and biopsy, cystoscopy is the most accurate way to diagnose a bladder pathology, mainly because it gives you a clear picture of what's going on inside the bladder and gives you an opportunity to get a specimen for pathologic examination. Lastly, let's talk about casts. Casts are imprints of the insides of renal tubules, as cells or other material can clog up those tubules and later be flushed out into the urine. Here is a list of high-yield buzzword descriptions of casts seen on microscopic analysis and the clinical associations you may be asked to identify on the USMLE Step 2. First, red blood cell casts are often associated with glomerular nephritis, whereas white blood cell casts are associated with pyelonephritis. Eosinophilic casts are seen in acute interstitial nephritis. Hyaline casts are seen in dehydrated patients, whereas broad waxy casts are found in dialysis patients or patients with chronic renal disease. Lastly, those granular muddy brown casts are the hallmark of acute tubular necrosis, and those granular casts are actually made of dead tubular cells themselves. This concludes our discussion on diagnostic tests in nephrology.